Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Okay, so we'll get started. Hello, everyone, and welcome to this week's edition of Can COVID Speaker Series. Thank you for joining us today. My name is Rosa Stalteri, and I lead the research and evaluations team here at Can COVID. And I have the great pleasure of introducing you to this week's speakers, Dr. Sue Bookey-Bassett and Dr. Patrick Neumann. Dr. Bookey-Bassett is the assistant professor at the Daphne Cockwell School of Nursing at Ryerson University. And Dr. Neumann is professor at the Department of Mechanical and Industrial Engineering at Ryerson University. And our title for today is Quantifying Nursing Workload During the COVID-19 Pandemic, a Simulation Approach. So just a few things before we do get started. We did save some time at the end of the presentation for a Q&A session. So please do enter in your questions to the events chat and ensure that you do select to everyone when doing so. And finally, we do have a brief announcement that we will share at the end. So without further ado, I will now hand over the mic virtually to Drs. Bookey-Bassett and Dr. Neumann. Thanks.
Thanks very much, Rosa. Today, it's my pleasure today to present on behalf of our team. Dr. Neumann and myself will be presenting a new simulation modeling approach that is in the early phases of development. This program of research represents a collaboration between engineering, nursing, and ergonomics. And prior to the presentation, I'd just like to acknowledge our team members on this project, Dr. Sadine Qureshi, Dr. Nancy Purdy, Dr. Michael Grigg, and Helen Kelly, and acknowledge our funding from CIHR. Okay, so prior to the COVID-19 pandemic, we know that nursing workload has been a long-standing global healthcare issue. Heading into the pandemic, there were several indicators regarding excessive workloads experienced by nurses. For example, in 2017, pre-pandemic, overtime and absenteeism costs were over $960 million per year. In addition, Canadian data indicate from other reports and studies indicate that healthcare is number one in lost time work-related musculoskeletal disorders. And other research also has found that 71% of nurses have experienced burnout at least once in their career. An earlier study by this team found that missed care tasks, so nursing tasks that were not completed before the end of a 12-hour shift, added up to about 25 to 31 tasks per 12-hour shift. And so in this study, what we wanted to look at is how does the impact of COVID change some of our workload indicators? And I'll be explaining that further in a second. But all of this was the backdrop to the beginning of the pandemic, where nurses experienced in the first wave stress, in the second wave burnout. In the third and fourth wave, we're now seeing increased rates of nursing turnover, such as early retirements and some nurses even leaving the profession. What's concerning about these data is that it's the younger nurses that we're now seeing that are leaving nursing altogether, those that are in the 20 to 30 age group, which is different from what we've seen in the past with some trends where we've seen nursing turnover over many decades. We've seen different patterns, but now we're seeing younger nurses wanting to leave the profession altogether. So that's quite concerning. So we know that reports from much what we see in the media, as well as current research, is telling us that nurses are even more overworked and stressed and burnt out than they have been in the past. We know that these working conditions are unsustainable. And anecdotally, we know from our own ongoing research that in many Toronto hospitals, at least, we're seeing high rates of turnover, and we're hearing about nurses just coming and going. Nurses, some of our colleagues that we're working with in some of our research are constantly hiring new nurses. And so it's quite concerning, and we wanted to be able to look at new ways of sort of developing solutions to this problem of workload. And so doing this by using expertise from nursing, ergonomics, and engineering. So using a simulation technique from engineering called discrete event simulation, or DES for short, we set out to simulate nursing workload on a medical surgical unit and then test how workload changed under pandemic conditions. So for example, caring for COVID positive patients and adding the IPAC routines of donning and doffing to determine the impact on nursing work and patient care. Evidence supports the direct and indirect care or indirect relationships between nursing workload and quality of patient care that's actually delivered. But we wanted to look at a tool that can be used virtually to assess and quantify the effects of changing work design policies and proposed innovations on nurses and patients before they're actually implemented. So for example, what happens if we change nurse-patient ratios? What happens if we change how we alter the design or alter the patient care assignment? So does it matter if nurses are assigned to patients that are in rooms that are side by side or around different places within the unit? And how do these IPAC routines impact the workload that nurses have? So rather than using a trial and error approach, a research program was launched to develop and test and validate a novel approach to understand the impact of these design policies on nurses' workload and care quality using DES. So what is DES? So it's an operations research tool that can be used to simulate the process of care delivery for nurses on a task-by-task basis. It is used to assess and predict the efficiency of a proposed or an existing system. And it's been used in a variety of other fields such as manufacturing, aerospace, and service industries. So in developing this model, the simulated model was developed created using three key inputs or objective sources of data. First, we had historical care data, patient care data, that was obtained as part of a workload management system known as GRASP, and a report with the GRASP data from an acute care hospital unit. This data provided information about the care provided to each patient and included such things as care tasks delivered, as well as their frequency and their duration. The second source of input into the model development was the unit layout. So the physical layout of the unit or the architecture of the unit, and this was obtained by physically measuring the entire unit using a laser measuring device. And the third source of model input was logic related to the nurse movement patterns and their priority logic. So what this refers to is, how do nurses go about doing their day-to-day work? How do they logically plan in their mind how they're going to provide one care task versus another? And how do they set priorities for their care when they're going about providing their care? COVID-19 specific tasks, such as donning and doffing of PPE, as well as other nursing workload care tasks, were obtained by video recording an experienced RN who mimicked the care delivery postures and actions for all the care tasks that were found in the GRASP system. And these were modeled using a software program called 4D Wattback. Dr. Neumann can speak to that if people want to know more details about that when we get to the question and answer page. Okay, so here you'll see on the screen the layout of the study unit. And what this is showing you is the movement patterns of a nurse as they carry out a particular task. So what this is showing is what a nurse might do, how they may walk around their unit as they're about to go perform a task such as insertion of a nasogastric tube. So as you can see, they go collect some supplies, they go to the clean utility room, they go into the patient room, perform the task, come back out, dispose of any dirty equipment, supplies, and then they go back to the nursing station. And these care task walking patterns were established in interviews with 2 subject matter experts, and they were 2 nurses with 8 years and 12 years of experience in the study unit work environment. The model outputs included 2 main categories. So one is nurse workload, and this was measured by several indicators, one being the direct care time, mental workload of the nurses, cumulative distance walked by the nurses, number of times they donned and doffed PPE during the 12-hour shift, and cumulative donning and doffing time. Care quality was measured by missed care delivery time, and care task waiting time. In addition, the model was developed with the following conditions. The data were collected during wave 2 of the pandemic, so during the fall of 2020. We maintained a nurse-patient ratio of 1:5, which was the pre-pandemic ratios on the study unit. It was modeled with the nurses having no breaks in their 12-hour time. And we adjusted care tasks that were being provided based on patient acuity. We varied the number of COVID-19 patients that were assigned to the nurse, and we modeled the care being provided over 12-hour shifts. So what did we find? So first of all, just to give you some information about how we validated the model was validated using a step counter, so a Fitbit worn by nurses and compared with the distance walked by the simulant nurse. The simulant nurses, so there was 8 nurses in this part of the study, and they ranged from 2 years to 18 years of experience. So these were nurses who actually worked in the study unit. The simulant nurse was assigned to the same geographical bed location and as the actual nurse to create consistency between real world and modeling conditions. And as you can see on the slide, the interclass correlation coefficient was, you may not be able to see it because this is on there, it was the overall ICC was 0.91. So let's go to the actual result. So this was, sorry, one second. So this validated this particular indicator. So now let's see what happened. So the results, what did we find? So first of all, the model showed that as the number of COVID-19 positive patients increased in terms of those assigned to a nurse, the amount of direct care time decreases. So just showing you the pre-pandemic was our baseline condition. And so again, this is showing where a nurse would have 5 patients, but none of them had COVID in this case. So as the number of COVID patients increases for each nurse, the amount of direct care time they're providing goes down. So does this make sense? It may seem counterintuitive because you would think with COVID patients that there's more care needs that nurses need to perform. However, what we found was that in the next slide, you'll see that nurses were actually spending so much time donning and doffing during their 12-hour shifts that this took away from the amount of time they're actually spending providing direct care. So you'll see here on the y-axis, donning and doffing increased as the number of COVID positive patients increased, ranging from 31 to 106 times in a 12-hour shift that they would don and doff. And on the right-hand side over here, represented by the red line, you'll see this is the amount of time, cumulative time spent donning and doffing. So if you see over a 12-hour shift, nurses could be spending up between 2 and 6 hours of their 12-hour shift donning and doffing, which we found was really shocking actually to see that 6 hours of a nurse's shift could be spent donning and doffing. And that's important to consider when we're thinking about how we assign patients. So if a nurse has 5 COVID positive patients, they're really not available to provide direct care because they're so busy donning and doffing their PPE. So the other outcomes that we found, so mental workload was measured as the average number of tasks in queue, or the number of tasks that a nurse needs to do for the patient. So in reality, when a nurse is busy with their patients, they'll be still thinking about, okay, I've got to do this, this, and this for my patients. And in the model, these tasks arrive to the nurses over time. So over the shift, you get a stacking of tasks that increase across the day. So the number of tasks in queue range from 22 at baseline up to 75 tasks waiting potentially when the nurse had 5 COVID positive patients. So that's a lot of stress on the nurse in terms of them thinking about things that they may or may not be able to complete by the end of the shift. And so the next indicator gives us a little bit more information about that as well. So if you think of, this is showing the care task waiting time. So the average time a care task had to wait before the simulant nurse could complete it increased by 70% across the varying conditions. Care tasks had to wait from about 0.75 hours to 1.2 hours when attending to COVID positive patients. And this did not include the tasks that were not completed at the end of the 12-hour shifts. So what does this mean? That means that patients are having to wait for care to be provided. And that again increases, that waiting time increases with the more COVID positive patients that a nurse may have. This slide shows you the distance walked by a nurse during a 12-hour shift. And so what we found here was that when caring for COVID positive patients, a nurse walked a range of from 8.4 to 10.5 kilometers per 12-hour shift. And what we saw here is this, what we call a plateau effect, when the number of patients ranged between 3 and 5 COVID positive patients. We saw that the walking distance didn't really increase any further, and we speculate that that's likely because of the fact that when the number of COVID positive patients increases, they're providing less care, and they're perhaps doing less walking around the unit as they're donning and doffing with the care of the ones that they are caring for. So less direct care again. In terms of missed care, here we show a range of the 48 to 143 care tasks missed when caring for up to 5 COVID positive patients, in comparison to 31 missed care tasks pre-pandemic. So again, missed care, just for definition purposes, referred to the number of care tasks that were not completed before the end of the simulated shift. We noted this in terms of the number of missed tasks as well as the type of missed tasks. So this was an increase of 353% that was observed from the baseline to the baseline pre-pandemic condition 2 up to having 5 COVID positive patients. And the highest percentage of missed care tasks included those related to teaching and emotional care patients, as well as documentation tasks. So why is this relevant? It tells us that nurses are prioritizing direct care for their patients, as they should, but it has implications potentially for at the system level in terms of patients not receiving emotional care or teaching before they leave a hospital setting may result in increased readmission rates and therefore cost to the system in the long run. And in terms of working time, missed care levels would require up to 9.6 hours beyond the shift for completion. So what that's saying is that in order to catch up, if you like, care that wasn't provided during that 12-hour shift, we need a lot of extra time for that care to be completed. So in terms of implications, so this slide is really speaking to implications at the unit level. So under these new IPAC routines, we see from our model that direct care time is reduced and that nurses could be spending up to 6 hours of their 12-hour shift donning and doffing. And we also see that with the more COVID patients, the potential for more missed care and increased wait times for care. So how might these results be used at the unit level? In particular, nurse managers or healthcare leaders in organizations, how could they use some of these results in perhaps redesigning care or rethinking how they might provide care? So first of all, we know that caring for COVID positive patients is physically and mentally demanding work for nurses. We know that nurses need recovery time, and therefore they should be getting breaks in their 12-hour shifts. And we know certainly from some evidence and also anecdotally that nurses are still not always getting their breaks during a 12-hour shift. The results may have implications in terms of how we think about making our patient care assignments. So again, thinking about is, a 1-to-5 nurse-patient ratio currently even feasible for nurses to get the care done by the end of the shift? According to the results that we've shown here, it's too high of a patient ratio. They're not able to complete their tasks by the end of the 12-hour shift. Or maybe we need to think about recognizing that missed care, such as teaching and emotional care, is going to be missed when nurses have these patient ratios that they have right now. And so are there other ways of thinking about staffing that we could use unregulated care staff or other care providers to help with some of the indirect aspects of care to assist nurses in ensuring that patients are getting all of the care that they need prior to leaving a hospital setting? And it's important that we factor in some of these issues related to wait times for tasks to be completed. So if nurses are busy donning and doffing, they may not be able to get to some of their other patients in as timely a manner. And that's important in terms of patient safety and being able to make sure that we're surveying patients. So perhaps something like hourly rounding is even more important than it had been or had been thought about prior to COVID. And again, thinking about implications for different models of care. Again, thinking about who the team members are as well on the team, and are there different ways we can use technology to help monitor patients when staff are extremely busy with IPAC care routines and they may or may not be able to actually physically get to a patient's room, but can we use different forms of technology to still communicate with our patients? And at the system level, how might this approach be used? So we've thought about a couple of things. So we know that there are limited measures to really quantify workload. And this is one tool that provides some of the answers or potential answers. We know that it's important to understand the drivers of workload and care quality in our current system. So what's driving? So what are the inputs of the, for example, in the model that influence care quality and the outcomes for both nurses and patients? And we think that this modeling has the potential to establish and verify achievements of standards of care. So for example, we discussed how much care is being missed during a 12-hour shift, but is there really such a value as a missed care value that's acceptable? We don't really know the answer to that question. And most of us would probably say, no, patients should be getting all of their care. But what's acceptable to be missed and what's not acceptable to be missed? We also think there could be implications in studying how the model can help answer questions related to new new layouts or physical designs of healthcare units and what impacts that might have on both nursing workload and patient care. And finally, we think that the model offers the potential to avoid magical thinking. So in other words, just when we see policy changes being made at various levels, are we just imagining that care is going to be provided as it should be, or expecting that the answers are going to be there, but really they're not going to be there in all of the cases. And so we know that what gets measured gets managed. And now we have a tool that can be used for decision support, whereby you can proactively determine the impact of design or operational changes on workload and care quality. For example, additional hours of care. Will it be enough to change the outcomes? So in terms of next steps, this slide is just showing you a little bit of what we've got in the works right now. We're currently adding some of the biomechanical workload data into the study, this current study. We're also looking at adding in fatigue tracking capability for both intershift and intrashift factors related to fatigue. And although this study focused specifically on the increase in workload related to COVID-19 patients, we think that this modeling approach has potential to answer questions that are important to both healthcare leaders and decision makers. We've had interest from both complex continuing care and long-term care settings in measuring workload. As we know, the acuity and complexity in patients in residence in these settings has dramatically increased, and they require much more care than they did 10 years ago or so, or in previous legislation that was set up to design the funding mechanisms for these sectors. And we think that it could help answer the question, for example, of whether 4 hours of care per day for residents in long-term care is really enough in terms of time. And we're also considering building in some economic analyses components into some future research. And so I'll end with this final slide, which provides some of our newer data from the same study, illustrating the cumulative lumbar load in caring for COVID-positive patients. And so to make sense of these data, what this is showing is that cumulative compression values with 21 meganewton seconds and more have been consistent with injuries in the manufacturing sector. So as nurses are assigned to more COVID-positive patients, their cumulative load decreases as they spent the majority of their time donning and doffing, which is less physically exerting work than some of their direct hands-on care maybe. So that's important in terms of that 21 is just really an indicator in terms of workload or lumbar load comparable to others in the injuries in the manufacturing sector. So that's important. What implications might there be for these results going forward? So we'd be interested in hearing your thoughts and answering any questions. So I will stop there and open this up for questions and discussions. And thank you very much for listening to the presentation. And I'll
Thank you so much,
sharing.
Dr. Bookey-Bassett. And Dr. Neumann, you're more than welcome to show your face. Perfect, there you go. We have about a minute to answer questions, so we'll try to get through them. It was a lovely presentation, thank you so much. So we'll start with this one. I wonder if the team would also consider additional psychological factors, predictors to the model. So for example, emotional labor, self-regulation, goal setting, regarding future directions. Would any evidence-based interventions help to mitigate the negative effects of workload on the outcomes? So I'll hand it over to Dr. Bookey-Bassett to answer that one.
I think that I'm going to pass that one to Patrick. I think it's a really good question, so thank you very much. And I think definitely it has perhaps a role to play. But I think in terms of the design of this specific model in relation to the computer simulation, I think Patrick's better to answer that question than me.
Those are really important factors, but they're very difficult to include in a task-by-task simulation model. So we would need to know what levels of emotional labor are associated with individual tasks quantitatively, how their time profile varies over time and what the response is to those over time. And all of that is very, very difficult to bring to mathematical models. We've done a little bit of work in system dynamics modeling to look at some of those aspects at a higher level, but you get disconnected from the design of the system and the way these very, very pragmatic models work. So that's a difficult frontier to move into for sure. I think in the outcomes of what it means to be overworked, what it means to have 6 hours of work left to do at the end of your shift, I think that's where we need to start to look at interpreting the results, even if they're not built into the causal drivers in the model. So that's a few comments there. Very, very difficult, but also very important area. Thank you.
Perfect. And then the next one we have here, I think it's for both of you. So this is a two-part question. How can we best support nurses or even prioritize underlying issues? And then the second question, for example, is addressing the nurses patient ratio more important than improving decision support tools and technologies? So whoever wants to start that one.
I can start. So thank you again for that question. So I think supporting nurses is such a key question. And I know we've seen, we've seen things such as wellness programs popping up in organizations that may or may not have been in organizations prior to COVID, but that's only a small part of the picture, right? That's, we don't blame nurses for having stress and burnout related to their work environments. And what we know from over time, I think from both of our perspectives looking at nursing work life is, we keep changing things within the work environment for nurses. We keep adding things on, but we never ever take away. The staffing ratios that we have in place now haven't really changed over decades, or perhaps maybe not decades, but at least over the last decade, where patients in both health acute care settings as well as others such as long-term care and complex continuing care have become much more sick, much more ill with complex illnesses and chronic conditions, and we've never adjusted the staffing numbers. So there's a lot of factors that come into this at the system level, at the organization level. We're hoping that this work will highlight by simulation how these different these different IPAC routines, et cetera, are impacting workload. And we're hoping that we're going to get some uptake from some decision makers around, okay, this technology looks great. What else can we use it to answer some of our questions so that we can, think about it proactively as opposed to reactively. And I'll pass it over to Patrick if he wants to add into that.
I think that's just it. I mean, if the problem is massive overwork of nurses, resiliency training is not going to get you out of the problem. You need to manage your system. You need to manage your employees. And that means reasonable workloads for nurses. And this is a tool that helps you figure that out. That's sort of what we're offering here now in the pandemic condition, but in any other conditions or normal or abnormal conditions, we can start to tell you what your workloads are going to be. And that's, I think, the magic of this particular modeling approach.
And we'll end off with this last question here because we're a little over time. In your future studies, will you be looking at how the pandemic has changed nursing students' workloads during their clinicals? Are nursing students finding it increasingly difficult to get hands-on experience during this time? And maybe is that something that we can look to in the future as to help relieve some of the work from the staff nurses?
Yeah, I think we've had a similar question in a previous presentation. I think there's two things in that question. One is, Are we looking at this from the perspective of the nurse who's having to be a preceptor for a student? Therefore, it's adding on to their work time, but in a different way. And so trying to capture that extra workload of precepting a student, or is it really looking at the student workload? We haven't really talked about that yet. And I think it would be worth having a little bit more of a dialogue with nursing students to really understand what their concern is, because I currently teach fourth year students and we start them off with looking after one or two patients and they work their way up to the full patient care load. So I think in order to, we'd have to have further dialogue about that. What is it that the students are concerned about that they would want us to have a better understanding of?
All right, so I think we'll end the session here today. I just want to take the time to thank you, Dr. Bookey-Bassett and Dr. Neumann, for sharing this wonderful research. And I'm looking forward to following up with the future results that you guys will bring. And just to say thanks to our participants as well for joining. The one announcement I do have is that for next week's speaker series, which is, as you know, every Tuesday from 4 to 4:30 Eastern Daylight Time, we will have a session on the Chinese Canadian experiences during COVID and the cultural meanings and practices associated with masks for Chinese and non-Chinese Canadians. So this does conclude today's event. Thanks again for joining us, and we'll see you all at the next speaker series. Thanks so much.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.